We shall move on to our first speaker of this session, Dr. Craig CHAYA, who would give his keynote address on adding safety to glaucoma filtering surgeries. And following his keynote address, we will be going through a series of challenging videos of 4 minutes duration, which would come with a great learning tip of their own. On to you, Dr. Craig.
Okay,
Could
give
you
me
share your video?
Yes, give me just a moment. Okay. Okay, just a little bit of time here, just having to reformat. Okay, are you able to see my screen there?
Yes, sure.
Okay. Thank you so much for allowing me to participate in this webinar. It's been a pleasure to be able to be halfway around the world. It's about 6:36 a.m. in the morning here, just starting my day here on Friday, and I'm very honored to be here with such a distinguished panel of experts. And I feel really honored, as I feel very junior to many of you who have so much experience than I do. And what I'm going to share with you is 8 tips to making trabeculectomy safer. This is going to be fairly practical. I hope that you can take some of these tips right now, today, or I guess maybe tomorrow when you work, and add these to your armamentarium as you tackle trabeculectomy. You know, trabeculectomy has been around for a long time, and I don't think it's going away anytime soon. This is a procedure that we still do here, despite the advances in MIGS and new devices coming in the pipeline. We do have patients that need low pressures, and as of yet, there's nothing that seems to be as good as a trabeculectomy in terms of getting the pressure lower. The other advantage of trabeculectomy is it's fairly cost effective still. There's minimal instrumentation that is used. And of course, we're using the patient's own tissue to create a fistula. So I have no financial disclosures. So I just want to give tribute to my mentor, Dr. Alan Crandall, who many of you knew and were exposed to and benefited from his teaching. And this is something that he said a lot during cataract surgery, but I think it also applies to trabeculectomy surgery. And that's that a lot of surgery is about understanding physics. We need to understand the physics of flow, of fluid dynamics. But one of the other things that we also need to understand is tissue modulation and how the bleb forms over time and surface area. So starting at number 8, I want to share with you that it's important to handle tissues with care. You have to have the right instruments for the job. And I would highly recommend, if you don't have it already in your set, to have non-tooth forceps for conjunctival dissection. Here you can see in my diagram, I have 3 different options. I personally like to use the Fechner forceps on the left-hand side. Many of you have the CAW clamp, which is a conjunctival clamp, which is wonderful for being able to hold both tenons and conjunctival tissue together. Notice that the platforms are serrated, okay? And these serrated forceps are wonderful at being able to gently hold tissue atraumatically. We also have the Chihara forceps, another type of conjunctival forceps. We have a version that we use here. It's called the utility forceps, or we know it as the smooth forceps, even though it's not technically smooth like a tying platform. It has serrated platforms in order to atraumatically hold the tissues. As part of our instrumentation for being able to perform dissections, I also like the Blumenthal conjunctival dissection. This is an instrument by Dr. Blumenthal from Israel. It's a smooth biconvex disc. It has a 21 millimeter shaft, and it's used to gently lift off the tenon's tissue off of the sclera. It's a wonderful instrumentation rather than using scissors to spread, which can sometimes cause tear outs of your peritomy. This dissector allows you to atraumatically dissect the tissues in a very broad and posterior fashion. So here I'm going to just show you some of the instrumentation that I would use for a typical dissection. And one of the things I want to point out here is it's very important to make sure that you are sub-tenons. Not in this video frame, but just prior to me placing the Blumenthal dissector back, we've handshaken the tenons tissue up into our forceps that is holding the conjunctiva. So we're holding both layers at the same time. This is critical to get this dissection plane down to bare sclera. We don't want to be dissecting intratenons or subconjunctival. So again, I'm handshaking the tenons just a moment after we dry, really being very meticulous in bringing the tenons together, and then using the Blumenthal dissector to aid traumatically. This Blumenthal dissector can be pushed posteriorly. It also can be twisted axially in order to help free up the tenons off of the sclera. As you approach the medial or superior rectus, there will be some adhesions there, and it's not advised to continue to push over the superior rectus. Okay. Tip number 7 is to hydrodissect with lidocaine with epinephrine. I think this is a very, very easy and effective way to bluntly dissect the tissue off of the scleral plane, and it helps also for several reasons. If you're doing this case topically, which many of us do, it helps tremendously with comfort. It also helps with hemostasis. By having the epinephrine, you may not have to cauterize as much. And again, to help gently lift off the tenons off of the sclera. So this is the beginning of a surgery. I've opened up the peritomy, and we're just making sure that we're definitely under tenons. We haven't done the blunt dissection yet. This is just the very beginning stage of the surgery. And after I'm sure that I have an opening under the tenons, I'll ask my scrub tech to hand me the lidocaine with epinephrine. This is simply just on a 27 gauge cannula. And we have a lot of thin tenons here in Salt Lake City and thin conjunctiva. And it's very important to handle these tissues with care. And this is one way to gently spread through the tissue plane atraumatically to allow comfort to occur for patients and also to help with hemostasis. So a very simple, doesn't take very long, and a great way to be able to do this case effectively and topically, and patients are still very comfortable. Tip number 6 is making the sclerotomy just anterior to the scleral spur. Oftentimes we use some sort of punch to make this, and I would encourage you, if you don't have a punch yet, this is a great way to standardize the opening, to not make it too big, not too small. But what I want to show you is that on this left-hand diagram, if after we create our flap, if we go in with our punch and we make a punch that is too anterior, what happens is we create a valvular effect. The trabeculectomy flap lays over our sclerotomy and will actually compress over that area. Now on the table, you may actually get flow by pressing posterior to the flap. You may still get flow and give you the impression that you've done a good job of making a good punch. However, because the sclerotomy is too anterior, it will create a valvular effect and prevent flow long-term. In addition, on the right-hand side diagram, what happens if you make your punch too posterior? Well, we all know what happens. If you go posterior to the scleral spur, you're going to get iris prolapse and bleeding. For the vast majority of our trabeculectomies here at the Moran Eye Center, we don't do a peripheral iridectomy, even for phakic patients. And that has to do with the strategic placement of the sclerotomy. So where do we want that? We want it to be exactly just anterior to the scleral spur. Now, at first, you may make the punch a little too anterior. It's okay to take additional bites until you can just see right here, like I'm showing in this diagram, just the very back portion of the punch, which should be anterior to the scleral spur. And I'm pointing that out for you. This is important to visualize on the table to make sure that as you lift your flap, you can see the punch just anterior to the scleral spur. So here we're making our initial punch, and this is my fellow performing the procedure. We're turning a little more perpendicular, and now we're lifting the flap, and I can see, I don't see it yet. So I've asked him to make another punch until we can get to that right location where we're just anterior to the scleral spur. Remember that the scleral spur are parallel oriented fibers to the limbus. And there you can see it right there. I'll back it up just one more time to where you can see just the very back of the punch. Right there. And that location is key so that we don't have it too anterior, creating a valvular effect. Okay. Tip number 5 is standardizing the size of your flap. I truly believe that we're all excellent surgeons and we all have the right intentions, but it's amazing how the anatomy can change from small eyes to large eyes. So personally, I like to standardize the size of my flap. It's also important to find that smooth plane of the sclera. Many of you are very experienced dissecting through sclera, and you know how the fibers change. As we get more posterior, those fibers become much more smooth and uniform. It almost looks like, the best description I heard of this is almost like rice paper over seaweed. It's that look of very smooth rice paper over seaweed. Okay. Now, if your fibers are oriented very irregular, you know that you're probably 50% or less depth. It's important to have an adequate depth of your scleral flap in order to be robust enough to be able to hold up to surgery, and also long-term to prevent complications such as dehiscence and melt of the scleral flap. So I recommend that you try to be 50% or deeper. And in order to get to that right plane is to find that smooth plane, that look of rice paper over seaweed. Avoid cutting the sides of the flap too anteriorly. We know when we do that, when we cut those flaps too anteriorly into clear cornea, we may get side flow, and that's where we can sometimes promote that anterior bleb that overrides the cornea. We want to avoid anterior blebs. We want to push that flow posteriorly in order to get the best location of our bleb and the healthiest bleb over the long term. In terms of sizing, I use a caliper. Some of you have pre-marked trabeculectomy flap markers as well, and that also can work. And my personal choice is about a 3x4 millimeter. And it's important to measure 3 millimeters posterior to the proposed punch site, which is just anterior to the scleral spur. So that's not 3 millimeters back from the surgical limbus, but 3 millimeters just where I think that scleral punch will be. Tip number 4 is strategic mitomycin application. Many of you are using 0.4 milligrams, and that's totally appropriate for the type of population that you have there that has robust Tenon's tissue. And whether you inject or use sponges, that's not super important. What is important is the location of where you put that mitomycin. If you are not meticulous in doing the dissection down to the subtenon space, when you apply those sponges, you may be intratenons or you may be actually subconjunctival. And that is a setup for a future conjunctival melt, leaks, and then obviously endophthalmitis and feared complications that we all have. So in order to really be meticulous with this, it's important, again, to really get down to that subtenons plane, hold the tissues together, both conjunctiva and tenons, if you're using sponges to apply into that area. If you're going to be injecting with your 30 gauge needle or other type of needle, it's important to make sure that your needle is in the intratenons plane. Very risky to go too deep because you might hit the sclera and hit a blood vessel and cause a lot of bleeding. So if you are injecting, though, make sure you're not just simply under the conjunctiva, but you're in the intratenon space and allowing very broad, just as Dr. Pencaw taught us from Moorfields, very broad application of mitomycin is key to getting that posterior wide diffuse bleb. Finally, one thing that often gets neglected is the perotomy edge. If you are using sponges, it's important to not allow the mitomycin to expose the perotomy edge. Why? This is what leads to wound leaks. They could lead to early failure. Now we're going to talk about suturing. This is going to be my next tip, but I first want to show you the traditional suture patterns for trabeculectomy is to place these right at the corner of the flap. I have nothing against this, but I want to show you what I think is a better way advocated by Dr. Pencaw and the Moorfield Safe Surgery System. So sometimes if we get too much flow, we may put additional sutures here anteriorly in order to compress the sides in order to prevent flow. So one very simple tip endorsed by Dr. Pencaw is to actually place these sutures tangential to the corners, but not right at the corner. And as you can see, this is just a variation. Instead of placing those sutures right at the corner, you place them just anterior, still in a tangential fashion. And so what you do is you limit the number of times that you have to pass sutures through the scleral flap and limiting the amount of potential suture tract leaks. Here with this tangential closure, you get both side compression as well as posterior compression in order to promote that posterior flow. We're down to the last step, tip number 2. And I know this is controversial, and I will tell you in our particular population here in Salt Lake City, Olagen Collagen Matrix does make a difference. I know one of your esteemed colleagues presented last time when I was on a webinar how they had done a study of Olagen Collagen Matrix and how it didn't really improve outcomes. But I want to show you that at least my technique is such that when you place this Olagen Collagen Matrix, it's important to place it posterior, so not directly over the flap. The collagen matrix lasts for about 3 months, and I have noticed in my experience that it prevents inferior bleb migration. If you have overfiltration, it prevents that bleb from tracking inferiorly and causing that exuberant, very large bleb that is uncomfortable for patients. And one of the final tips with using Olagen Collagen Matrix is that at the end of the case, I inject beta-methasone in that space, and that allows the collagen matrix to become a depot for steroid, and so patients don't have to use what I think is excessive amounts of steroids. And we know that many patients really don't take steroid drops as described more than 4 times a day. So what I do is after the Olagen Collagen Matrix is back posterior to the
So 15 minutes is over, sir.
I will just about done. I will hydrate it with the steroid. Tip number 1, my last tip, is leave a limbal skirt at the limbus and use the smallest needle for the peritomy closure. I've drawn a diagram for you. I used a modified Weiss closure with the Condon closure technique in order to close this peritomy in a running horizontal mattress fashion. And I use one of these types of needles. My preferred is the VAS 100-4. This is a vascular needle used to sew in blood vessels and exquisite in terms of really limiting the amount of potential suture tract leaks. So there you have it. Those are my 8 tips to making trabeculectomy safer. I hope they're practical, and I hope you can use some of these today in your surgery. Thank you very much for your time.
That was a wonderful talk, Dr. Craig. Very, very relevant tips. I would ask you some questions, and I would want Dr. Shushmita and Chandrima to add their thoughts to it. Some of the questions which I planned, you've already said in your talk. So one very basic question is, how do we minimize the incidence of conjunctival leaks besides the points which you said?
Yes, so I think it's very important, as I've mentioned, having the right instruments for the right job. We are working with tissues, and there's no better surgical expertise than the glaucoma surgeon working with conjunctiva, but you still have to have the right tools. So these are simple things, non-tooth forceps. Really, we shouldn't be using things like 0.12s or anything with teeth that could potentially cause buttonholes in the conjunctiva. The other one that I would just want to emphasize is the mitomycin application. You have to avoid exposure of the peritomy edges. It's something that we don't think about. Sometimes we allow the mitomycin to spill over into different areas, but be very meticulous to not allow exposure of the peritomy edge.
Probably also not avoiding the side cuts. And conjunctival suture, you would prefer using a 10-0 nylon?
So we are fortunate to have 10-0 Vicryl. I know it's expensive. I think 10-0 nylon is a very suitable suture to use that's readily available. But I don't know what's available in India there, but I would say if there's a way you can get the manufacturers to create the smallest needle attached to the for your swedge with the suture, that would be preferred. But sometimes you just don't have a choice. You have to use whatever's available. So in that case, you really want to just make sure that you get an adequate horizontal mattress closure is what I'd advocate, and make sure that it's a 2-layer closure. Don't allow the tenons to retract back where you're only closing conjunctiva to the limbal edge. It's important to make sure you handshake the tenons, and with, you don't have to have it with every bite, but periodically bite through the tenons to be able to advance it anteriorly so that it doesn't migrate posteriorly. When you allow the tenons to migrate posteriorly, you over time will get a very, very thin ischemic bleb over the conjunctiva. It's just too thin and it's at risk for leakage.
Dr. Murli, would you want to take a question?
Yes, Dr. Craig, I wanted to ask you, it is said that you should avoid the scleral flap in an area where there are perforating vessels. Is it possible to identify these perforating veins so that we can avoid them? And is it possible to position the flap in such a way that you can avoid these perforating vessels?
It is always possible, but sometimes you don't have a choice if you have limited real estate to work with. I have still been able to successfully do scleral flaps where you have perforating vessels or episcleral veins. And I think it's important to realize that you just have to be very gentle with your cautery. Try not to over cauterize the tissue. I think that's an early trainee mistake, is that we tend to be very exuberant with our cautery. And when you do that, you shrink the tissue and you'll have less scleral flap tissue to work with. So very important to be gentle with your cautery and limit that as much as possible. So part of the reason I've been able to not use as excessive cautery is I think the lidocaine with epinephrine to blanch the vessels. Also, brimonidine soaked on Weck cells helps to blanch some of the blood vessels as well. And if you do have a vessel, one thing about the vessels, you don't necessarily have to cauterize directly right over that opening in the sclera. Maybe you can cauterize just a little bit posterior, and that should allow that. It will ooze a little bit, but by the end of the case, it should be basically a ghost vessel and shouldn't really lead to any bleeding.
Dr. Shushmita, I want to ask you a question. I would want Dr. Craig to add his thoughts to it. How do you titrate your flap suture tightness?
So we've moved on to doing releasable sutures completely.
Yes.
And we've learned with time that the low pressure is not something to aim for. And we've also learned that the trabeculectomy, which has pressure in the higher teens on the next post-op day, are the ones likely to be better. And this is age-old teaching of primary and secondary AIOS, which I suppose held true because that was what was written in Duke Elder half a century ago. That a primary AIOS is that which is secreted to maintain intraocular pressure, whereas a secondary AIOS is that which is actively secreted when you have hypotony. And that's what you don't want. So you don't want hypotony and you don't want inflammatory AIOS pouring in to maintain your intraocular pressure. So to answer your question, we really do quite tight suturing with very, very minimal flow because we know that we are going to release that suture maybe in a week's time. With mitomycin, you can extend it to about 2 weeks as well. But we like our trabs tight, and we like it to be physiological pressure at the end, which we check with the bud at the end, but no real titration of the flow, so to say.
Dr. Craig, you would be agreeing to it, I suppose, totally.
Yes, I would agree with Dr. Shushmita said. One of the tips that I train my trainees to look for is after you've adjusted, to also use adjustable sutures, of course, on the table to titrate the tension. But when you're done with what you think is the appropriate number of scleral flap sutures, is to just allow yourself to pause and look at the back edge of the scleral flap. If you see just it kind of slowly oozing in and filling into the back of the scleral edge, that's what I'm aiming for. And that's where it takes experience to be able to have patients to monitor for that slight oozing and filling in of that scleral groove that you created at the posterior flap. That's what I aim for. And most of the time it works very reliably. And then, as you said, we can release those sutures within the first month to titrate for the right pressure.
Okay. So do you use wound modulating agents in the post-op regimen to minimize any challenges of angry bleb, Dr. Craig?
Yes, so we use a variety of things. One would be, I would say the most common would be 5-FU, fluorouracil, and I will inject that early on. If I see that the injection is quite exuberant and quite aggressive, despite steroids, then I will certainly inject mitomycin. And I may do that serially. So I may do it 1 week, have them come back the next week, and if it still looks angry and red, I'll do another injection of 5-FU. And usually after 1 or 2 injections, you start to see the injection start to subside. The other thing that I mentioned is that I find that I'm using a lot less wound modulation posterior or after surgery, because at the end of the surgery, I'm using a long-acting steroid, injecting that subconjunctival next to where the bleb space is. I've been using betamethasone. This is a potent steroid, but it only lasts aggressively for about 2 weeks. So it's not like triamcinolone. If you use triamcinolone may stay around for 4 to 6 weeks, and you may not want it that long. And so I think betamethasone is a nice adjunct to last for about 2 weeks, and it helps to augment what the patient is doing topically. And I find the injection reduces dramatically within the first 2 weeks. So I'm doing a lot less 5-FU. If I have a scleral flap that really starts to seal down and is aggressively fibrosing, I always tell patients when we do the original trabeculectomy, this is a staged procedure. We're going to do the original trabeculectomy, but we may have to go back and do a needle revision within the early postoperative period to ensure success. So if you give that expectation to patients right away, I think it's important to let them know that this is a staged procedure. The hardest work is in the postoperative period, and we're going to still make this successful, but it may require us a trip back to the minor procedure room or operating room to lift the scleral flap. And at that time, if I have to do another needle revision, I will do another application of Mitomycin C. We use 0.2 milligrams per ml, and I inject 0.1 mLs of that concentration.
Dr. Devantuli, do you have anything to add in which we may differ?
So we are using a lot of the post-op wound modulation. We use Mitomycin C, typically a quadrant away from the Bleb site. And for the audience, I would recommend 10 times diluted to what you have used intra-op. So that would be a safer concentration in lesser experienced hands. And that is the only thing I wanted to add. 5FU is a little messy here, Dr. Craig, because it's one-time use and people tend to waste it. So people have moved on to Mitomycin C.
And perfectly appropriate. I think one thing that we all have realized as we practice around the world and as I've traveled around the world, all of our populations are different in unique ways. So what I do here in Salt Lake City should be no reason that you should do exactly what I do in India and vice versa. So if I were to use 0.4 milligrams per ml of mitomycin, I may just wipe out most of the conjunctiva in our population here. So yeah, tailor your practice towards what is working in your, and I'm so happy to see some of these tips and to be able to share these tips with you. But you may find that these don't work in your particular population. But I think there are some things that we can agree on in terms of universal principles to make trabeculectomy safer. But yes, anything that can be helpful to prevent that fibrosis.
I would take one last question from you, and I would want Dr. Chandrima to add her thoughts too. How would you manage a weeping bleb in the early post-op phase? Dr. Craig?
Oh, I'm sorry. I thought someone else was going to go first. So a leaking bleb. So I think it's important to identify, I'm assuming when you say leaking bleb in the early postoperative period, we're talking about the conjunctiva. Yes. Yeah. And so this is crucial that you seal this off immediately. And there's a couple things. If I have a very small leak at the peritomy site, I may choose to observe or just start to reduce the steroids. We know that steroids are great for wound modulation, but this is the time where you actually need to promote wound healing and allow the peritomy to seal. So I may temporarily stop the steroids or reduce them significantly, see the patient very closely. As soon as I see the peritomy leak seal up, then I'm going to add the steroid back on again, okay, in order to reduce the injection and prevent long-term bleb fibrosis. So adjusting the steroids is critical. If I have still a persistent leak despite the reduction of steroids, then I will use a large diameter contact lens. We have like a 14 millimeter contact lens that we can place over that bleb space or over the peritomy, and that helps to add some compression and allow time for that peritomy to heal up. Now, if you have a significantly large wound that you may have missed on the table, or the patient rubbed their eye and caused a wound dehiscence, you may have to take that patient back to the operating room and re-sew the peritomy back. But I think those are important things, is that you seal it off immediately. And once you seal off the peritomy, then you have to re-jump back into the process of aggressively treating with steroids and cutting the scleral flap sutures in order to maintain the bleb space. If you cut the sutures too late and wait too long, the conjunctiva and tenons may seal to the sclera, and then it may fail already. So it's very important to watch these patients very carefully. Try to get the peritomy to heal as fast as you can, then go back and re-aggressively apply the steroids and then release the sutures as needed.
Dr. Chandrima, you have anything to add before we take one final question?
Yeah, not really much to add, except that I wouldn't reduce the steroids. I'd keep the steroids as they are normally, as I would tail it off, but I would definitely use a bandage contact lens, a big sized contact lens, and then see what happens. Most of the small leaks actually with bandage contact lens do very well within a week, and you can remove the lens and you're absolutely fine, basically. And of course, if the leak still persists, then you have to think of taking the patient to the OT once again.
Right.
Dr. Murli, you want to add something?
Yeah, I wanted to ask Dr. Craig, sometimes in the postoperative period, you see a reducing bleb height, but the pressure is still in single digits. So what would you do in that situation? Like if the bleb height is reducing, pressure is rising, you can remove a releasable suture or do a laser suturolysis. But if the bleb height is reducing and the pressure is in single digits, how do you manage that?
So I've been less concerned about that issue since using Olagen, because when Olagen becomes hydrated, it will swell and it maintains the bleb space. But if you don't have access to Olagen, I think the important thing to understand is when during that period is this occurring. So if it's early on within the first month or two, it may be that the patient is still aqueous suppressed from all their aggressive topical drops before. So just be patient. Over time, the pressure should start, or the bleb should start to hopefully rise as the aqueous production increases. But believe it or not, we may have some blebs that are low-lying blebs, but as long as you are achieving your target pressure, I'm not too concerned about the bleb height as long as we're being able to achieve our target pressure. Now, if you obviously, when we see that bleb height reduce, we have to correlate that with the pressure. So if the bleb height is reducing, but the pressure is going up, we know the bleb is on the road to failure and we need to intervene sooner. But if you have great pressures with just a very low-lying diffuse bleb, I think that's an ideal bleb, actually, is having a very low-lying posterior bleb.
Oh, absolutely. I was just going to say that, Murali, because the pressure is good because it's a good functioning bleb, and I think the diffuse bleb is much better than a higher bleb but less diffuse. So that the localized bleb is not good. I think that's an ideal description that you gave, Murali.
Any question, Murali, before we go on to our next speaker?
No, ma'am.
Okay. Thanks a lot, Dr. Craig. I would want you to be there as an expert panel for a few more of our speakers before you get back to your practice, just in case. And you have heard wonderful tips from you. I'm sure we should all hear it again to be